Welcome to the series of Healthcare Scene Google Plus Hangouts, where we sit down with top leaders in healthcare IT. Before we begin, I want to remind those watching live that you can submit your questions on the event page for this Hangout. If we have time, we'll try to incorporate them into the Hangout or answer them after. Our guest today is Mary Beth Haugen. Mary Beth has walked the walk of both HIM and HIT after serving as the Director of Information Systems and Health Information Management at Denver Health. Mary Beth was fully engaged in every step of Denver Health's EHR journey, and now she helps other large health systems with EHR and legal health record issues. In addition to leading her own team of HIM and IT consultants, Haugen Consulting Group, Mary Beth serves on the HEMA Foundation Board and formerly on the EHR Practice Council and as a HEMA Board of Director. Sounds like she's done everything, basically. If anyone knows how to cross the HIM and HIT divide, it's Mary Beth. I'm really pleased to have her here with me today. Welcome.
Hi, John. Thanks for having me.
Great. So we're going to talk about the legal health record today. So how about for those that aren't as familiar with it, let's start with the basics. What is the legal health record?
So the legal health record is what the organization is going to define as their clinical, regulatory, and health record. So it's actually a subset of all the patient database information, but the organization has to make sure that they follow all regulatory guidelines and CMS guidelines and create their own definitions. So unfortunately, not one size fits all for everybody, but it will entail what you're going to define as your legal record.
Interesting. So what's it look like? I mean, you talk to a lot of organizations. Are a lot of them really good at defining the legal health record, or are they not so good, or what are you seeing in the market as far as how well they're doing at defining it?
Yeah, I think we used to be really good at defining our legal health record back in the paper days. It was really kind of straightforward. Here is our paper medical record. Here's the information that we're going to put into it, and we're going to store it on the shelf and be good. As we become more and more electronic and we have the complexities of some e-discovery and other components, it's made it much more difficult to say, we're going to take a subset of all of this electronic data and make it our legal medical record. So it's just added a layer of complexity. We have data everywhere. We have a lot of information. And so I find that most organizations are really struggling, not only with their legal medical record, but all of their information governance and their information governance structure. We just have a ton of data. So what do we do with it?
Interesting. It sounds like to me that there's probably a lot of HIM directors out there that are sitting there saying, we need to define the legal health record, and the C-level executives are saying, why? So I guess that's my next question. Why should an executive at a hospital listen to their HIM director? Because I'm sure every one of them wants to do this. Why does it matter to define it?
So one of the most critical components on why we want to define it, let's take the worst case scenario from a litigation standpoint. So once we define what our legal health record is, that's the information that we're going to provide to a plaintiff, to a defendant, and if we haven't clearly defined it, I could give them different information, or I might give them inconsistent information. And the same way from a patient care perspective is we always want to provide the most up-to-date critical patient information, and so if we can start with what our definition of the legal medical record is, that gives us a good foundation for it. We can always provide additional information later. The other complexities around this is around retention. Now in the electronic world, it's like, oh, storage is cheap, we can keep everything. But we're required from a state-to-state level to determine how long we want to retain information. And it's really not cheap to keep all of this electronic data. So from a retention requirement, we're required to keep our legal record for X period of time, depending on which state we're from. And so once we define that, then we can say this is the piece that we're going to keep for the next 28 years if it's a pediatric record. You don't want to keep everything for 28 years. How could you manage that, retain it, etc.? Or you might choose to, but then you're going to have a strategy and a plan to keep all of that information and be able to produce it.
Right. So I want to dig into the retention stuff some more, but I think it was interesting the risk you talked about. One, it sounds like the advice you're giving is that for a legal health record, you want to have consistency, and that's why defining the legal health record matters, because if I've learned anything in legal is consistency is really important. Otherwise, they take that inconsistency and you're in trouble. And then the second one you said is interesting. So it's more about the patient care they receive, and are they getting consistency once again in what kind of information they get, so that then the doctor has all the information they need. Is that right?
Correct. You don't want to accidentally forget to give a key component of a patient's medical record if the request has just been, please send the appropriate information or send the legal record to a provider. So you're right on task with that. We want to make sure that we've got a plan so we're providing the right information. And again, that consistency from a legal perspective is definitely key. I want to define this as my legal record. In the instance of a legal hold case, you might be requested to put your medical records into a legal hold. And if you don't know where your data is or how to do that, then you could be up against spoliation, where we destroyed information by accident, but because we could provide the information that was requested, the jury's going to be told you got to assume that that information was bad. So, as you're talking to the executive team, really understanding we've got all of this critical data everywhere. How do we manage it? How do we deploy it? How do we release it? How do we retain it and meet all of these different standards and regulatory requirements? So, like we said, much more complex than it used to be.
Right. Now, it seems like, I think if I'm thinking as a C-level executive at a hospital organization, and my HIM director comes and says, we need a legal health record. If they tell me the legal implications, that speaks to me, but maybe they need to pair it with some cases of examples where some people got in trouble. Are there other things that they should do to make the case for a legal health record?
Yeah, I think not only legal health record, but all the components. I mean, we're required to define our legal health record from a CMS. We want to be, follow any of our accrediting agencies like the Joint Commission. So it is a requirement that we have it. I think what we need to be able to message is the complexity around it. And starting, and like AHIMA produced a great white paper around information governance, where we have a subset of this legal health record, but we're also maintaining all of this different data. But if I was going to talk to an executive, I would say, it's critical that I have the right information at the right time, that I can retain it and deliver it appropriately. And if I'm not managing and maintaining this, let's say, John, you come in and I accidentally code your case incorrectly. The physician diagnoses you with a cough, and I assign a code of liver cancer to your case. Yeah. So in that, now that we're so electronic, I've assigned that liver cancer code to you, and it's gone to every subsystem that I have. So it's gone to my lab system, it's gone to radiology, it's now gone to my billing system and my data repository. So I've sent that diagnosis off to your payers. Let's say you've requested life insurance. I've sent that information off. And so now in the electronic world, this misinformation can also spread. So the electronic world is awesome because now we have great information at our fingertips, but we can also have misinformation at our fingertips. So in defining our legal health record, I want to make sure that it's clean, that I have great data integrity, and we know that we're going to make mistakes. So how can I fix any mistakes? And I think assigning it, giving somebody, you don't want to be diagnosed with something that you don't have and have your payers or get denied life insurance because I accidentally flipped a code around and then didn't go back and correct it. So I think having those kind of conversations sometimes hits home.
Yeah, that's interesting. So, I mean, I've harped on this obviously enough, the importance of it, right? I think it's really valuable though. So let's hit some more of the retention policy stuff. I've seen something really interesting with retention policies, that in larger cities, they want to keep the bare minimum retention of what's possible, largely because of risk, I think, where they're like, oh, if we have it, then we're accountable for it. But if we don't, then we're not. And so, if the retention policy is 8 years or whatever it is for that state, they want to get rid of it. But I've seen the opposite in like a rural environment, where they want to keep everything for everyone because that person's going to live there forever and they're their neighbor and their friend, and they just want to have every piece of information for eternity, and so they're not as worried about the litigation. Have you seen something similar? And is that a bad choice for either side of the equation?
Yeah. I think, again, it goes down to the organization and why it's critical when we look at things around all of our information and our governance and our legal health record is to not do it in a silo. So you don't want exclusively the HIM director making all of these decisions. We need to incorporate information technology, our clinical staff, our informatics staff, and to say what's the need of the organization. If we're a high research facility, our retention period might make sense to be much longer than what's required because we do so much research. Or if we're a small community hospital that doesn't do that, then it might make sense for our organization just to meet the minimum requirements. Mm-hmm. So it really depends on, and I think it's a conversation that has to happen with multiple people within the organization to determine what's best. Also key to have at the table is IT, because we have run across situations where we want it to fall within a certain retention period, but we don't have the capability from an IT perspective to necessarily delete the appropriate information easily, or how we can go about managing that. So we don't want to put a policy in place and then the day before go up to our CIO and say, by the way, we have to destroy X amount of electronic medical records.
Yeah, well, that was actually my next question is, I mean, the EHR world has changed this, as you kind of described already. I don't even know many systems that provide, a way to kind of, for lack of a better term, delete, the medical record. Are you seeing this starting to shift where they have these features, or are we kind of at their whim?
A little bit of both. We're finally starting to see more of a shift of that. I think when EHRs first came out to the market, it was like, oh, you have this great electronic data. Why would you ever want to delete it? Of course we can say. And so I think now as vendors are truly understanding the rationale behind when it is appropriate to delete it, that we're able to work together. To have that happen. But it is very complex, and again, there's a lot of data in a lot of different systems, so we need to make sure that we're accounting for the data in every system when we're looking at our destruction policies. But I found it personally difficult, to get everybody on the same page and to get to a place where we can actually destroy data appropriately and easily. We haven't gotten to easy yet, but we are getting there.
Yeah, I mean, the easiest one I've seen is they switch EHRs and then 8 years or whatever, they delete the old EHR. Right. How do you handle all these old legacy systems? I mean, in some of these hospital systems, they have 100+ different records. How do you manage that from a legal health record perspective and a data governance perspective?
Right. I think the key is to know that you have legacy systems, what legacy systems that you have, and what data is on there is key. And then knowing that if you choose not to migrate that patient information or that data to your new system, that as long as you have that or you're required to have it, you're going to have to be able to produce it. So at some clients, we've run into the situation where we've had legacy data and just didn't really do anything with it. We had it in the closet. All of a sudden, we're required to produce it. So we're out on eBay trying to purchase the equipment because it's so out of date that would allow us to kind of extract that information. So you've got to really think hard about what's on your legacy system, how long do you have to keep it, and then make sure that you're going to be able to get information out of it. And typically now with organizations, especially large healthcare organizations that are purchasing physician offices and clinics and making them part of your organization, really taking some time and doing some due diligence to find out what legacy systems do they have kind of hidden away in the closet so we can account for them and then create a plan for them.
Yeah, I imagine staff turnover is another issue with a lot of those. They're like, oh,
Right.
we don't know anyone. Consulting companies are making some good money there, I think.
Well, it's helpful to have us because I think we're all so busy in our day-to-day jobs that it's like we just want to keep the lights on. And in healthcare, our primary goal is to provide that patient care. So our biggest concern is having the IT systems there and available and medical record information at the time of care. But we also have to think about all the people that are using all this information and data once the patient goes home.
Sure.
And that's where I think we've run into some complexities.
Yeah. No, I'm not knocking consultants. It's better than keeping a legacy person on staff.
Right.
It can be cheap.
Absolutely.
So,
no, I didn't take offense.
So the other thing that I know we discussed a little bit about this in anticipation of this is the idea that in the EHR there's one view of the data. In fact, maybe there's even multiple views of the data. Maybe in one place you see the allergies, in another place you see the full note, which may include the allergies as well. The medications are in one place, labs are in one, lab results, maybe the lab results are in a note. So, I mean, they're in all these different displays, which is the beauty of EHR. But that seems like it would offer a real challenge to the legal health record. And what do you output to a lawyer that wants it, or to a patient that requests it? What kind of stuff are you seeing there, and what are some good approaches to dealing with that?
I think you make a great point, and I think many of us that have been in this process for a long time learned early on that all of a sudden we had this great data at the bedside, but all of a sudden when I went to print out that nursing assessment that used to be a 3 or 6 page fold-out form, it now was 87 pages long, and so difficult to read, and you're giving a patient, a stack of 2,000 pieces of paper. So I think one of the things that many of us didn't do well up front when we were implementing our EHR was to really take the time to look at what our output is. And again, I think it's educating some of our vendors to say it's critical that we have this great information at the bedside, but there also is a purpose to have a file format, electronic file format, or paper that we can produce that is going to make sense to the patient and not create 20 million pieces of paper that we have to try and figure out just because we have one set of vitals per page. So the output is critical. I think it's some of the things that we don't typically think about. But when you look at the back end, we're reproducing that patient's medical record not only for patient care, but to support what we're billing. Many of us are up against tons and tons of RAC audits or different auditing things, and we need to be able to produce appropriate information to support our justification on why we got paid. And if we give them stuff that they can't make heads or tails of, it's hard. And so looking at that output and compiling it into where, again, we have kind of consistent medical records. So every time we print the record, it's printing the most information in kind of a format that our end users can use. It is to me critical, but I'm an HIMer by heart, and so being able to have release of information appropriately and have things for auditors is really key.
Mm-hmm. Yeah, it's interesting. We talk a lot about healthcare interoperability and trying to move the data around. And a part of that thinking is, we can kind of get rid of paper and get rid of the output to paper because we'll just be exchanging the data across, exchanges, direct protocol, whatever technology it is. But I don't think we've thought all the way through to say, okay, well, that's great with provider-to-provider interaction, even provider-to-patient interaction. But what about those other interactions where the insurance company, the life insurance company needs it, or the law firm needs it, or someone else who's not in the health system needs it? What does that output look like? That's a huge challenge I don't think we've addressed.
I completely agree. And we also need to look at our patient population. Some of our patients aren't comfortable with a computer or don't even have email, so we're still having to produce that piece of paper. And then, so we have kind of that generation that isn't necessarily using it. But I know for me, with my children, I still have to produce a paper sports physical, for school. So I still need that piece of paper. So I don't think that's going to go away. And you're right, the complexities of the interoperability are great. So it's going to be a while until we're completely paperless. And I think right now we need to build systems to be able to accommodate paper coming in as well as paper, leaving the organization.
Yeah. Well, no doubt. Now that 6-page thing became 86 pages, which we've seen.
That is so painful.
Yeah, EHR was supposed to get rid of paper, but in many ways it produces a lot of paper because that printer can churn it out.
Absolutely, it's crazy.
So let's ask kind of an extension of this. What really is the key to having a clean health record, and what are some good strategies to deal with making the health record clean?
Yeah. So I think there's a lot of different layers to this to make this work the best way possible. So again, kind of that information governance structure. We have to have, our executive staff engagement in this and understanding why this is so important and so critical. And we need to ensure that we have the right players at the table, because we don't want IT making these decisions on their own, or HIM or informatics, etc. So it's important that we've identified the appropriate resources at our organization to make these policies and procedures. And then in order to, keeping the data clean and the data integrity is definitely key. So understanding that from the time the patient hits the front door at patient registration, do we have a clean master patient index? Have we given our registration staff the right tools? Are we monitoring that? Because we're going to have medical fraud, we're going to have duplicate medical records, things are going to happen. So do we have processes in place and a data integrity team to say, oops, John, sorry I gave you liver cancer, but I am going to take it off of your problem list. I'm going to let the HIE know that I sent that diagnosis, or wherever we're sending that information to, that it was inappropriate. So it needs to start at the top, and then we need to make sure that we build all the way down to the foundation, all the key tools to keep that data clean, check our policy, make sure the legal health record policy and designated record set and all of those components are staying on track and are up to date, and our retention is reviewed. Lots and lots of stuff to do. And so, not, in my opinion, one person can't do it. We need a team.
Yeah. So it's interesting. A doctor told me that the thing he hated most about EHR was it perpetuates misinformation, which in HIE and the interoperability does it even worse. But you bring up an interesting point. Like, who should manage all of this? You said a team should be involved. Should there be different roles within that team, or how do you really approach that? And who should be involved and who maybe shouldn't?
Right. I think from my perspective, and again I'm biased with my HIM background, we need to identify and designate that custodian of the legal health record. And typically that HIM person is going to be your key individual that can take that medical record to court, that can manage the releases. So they need to be at the forefront of that data governance structure. But again, it's not just one person, like you said. An HIM person can't manage the knowledge around what the IT systems are capable of. I can say, from a regulatory standpoint, I need these elements within the output, but if I'm not partnering with the right people, I'm not going to get the appropriate output. Or if I don't have my clinicians on board, there might be key elements that aren't required in a medical record, but are key for the patient care that they want incorporated in it. So, I would put the HIM person at the helm as the custodian, but really standing alongside numerous people.
Interesting. I just was thinking about another example of why the HIM director likely can't do it themselves is you need a really good cooperation with the EHR and other health IT systems to be able to do your legal health record accurate. And I've never and maybe there's an exception, but I've never seen an HIM director tell an EHR vendor to do something and they listened. You know, like they usually, like they just don't have that relationship, right, with the EHR vendor. Maybe that's changing over time.
I think it's changing in some organizations. I feel like in the last organization that I was in prior to starting consulting, I had a great relationship with our EHR vendor. I felt like I was at the table for a lot of the discussions, and I think that was key to have kind of somebody, and I kind of felt like from an HIM perspective, I could bridge the clinical and the technical without having expertise in any area, but knowing that we need this clinical information, IT staff, why does it need to be there? And then we can bring in the regulatory components to say this is part of it. But I think it is key for the HIM individuals, and it's sad to hear you say that, but I think it's all too true that we're not at the table enough, and we're not partnering enough all the time with our IT vendors. But there are, I think when you look at some of these amazing organizations that have really aggressively moved forward with their EHR, typically I've seen HIM individuals at the table sitting next to the CIO and the EHR vendors.
Yeah, and maybe I was a little aggressive saying none, but
maybe a little aggressive.
but I mean, even if they're at the table, I remember my HIM director when I was working the day job came to me and she's like, they invite me to the meetings, but they don't listen to me. You know, I think about that often. You know that you know it's hard for them to have a voice that they feel like is listened to. And so when they say it with someone else, then you know, even if it's not HIM director, I think that adds more power. So you know, obviously, if you have a team effort, then you can accomplish more.
Absolutely, and it is our role, I think, as HIM professionals to provide that education and to make sure that our voice is heard. That's where I give a lot of credit to AHIMA in issuing that white paper on information governance and really serving what organizations are doing and starting to put together a plan on how we move forward and why this is so critical. Because unfortunately for a lot of us, or when I'm called in as a consultant, it's a little too late. So we've had an adverse event, we've had to do something in court, and then we're bringing it in, where I think if we can get ahead of the 8-ball, do some planning up front, you know, get some experts in there that understand the data flow and the data process and the required output, we'll be a lot better off, and it will be much easier. We won't have to recreate and, you know, customize and do different things that we all have done in our EHR systems.
Sure. No, I think a little investment now saves a lot of legal heartache later. And anytime you can avoid a lawyer, you've done well.
That's right. That's right.
Well, you know, we're at the end of our time, and I appreciate your insight. I think that's really interesting. Hopefully we gave some of these HIM directors some ammo that will help them be more successful and have their voice heard. So thank you so much for being with us.
Thank you so much for having me.